Okay, so we're going to do the subtalar manipulation. The way we want to do this is it is an inertial manipulation where your thumbs are essentially on the sustaneculum tali and your fingers are above the fibula. That way when you do this flick motion, you're not blocking it with your fingers there. This is the easiest position to get in. Explain to your patient what you're doing because they might not know why you're sitting with them in that position, and just say, hey, we're going to try to get a better manipulation or mobility in this joint, and you'll have done your motion assessments and been talking to them the whole time. What's nice about this is when you're on the sustaneculum tali and you're pushing, the inertia will just push the calcaneus in the correct direction. There are specific mobilizations for the anterior and posterior part of the joint, but I found those have not been as necessary if you do this one correctly, because it appears to work on both. But if not, we'll do directional ones. So then we get our thumbs and fingers in the right position, we lift and we drop down, explaining to the patient, getting permission, etc. So then we're going to lift up and flick like that. So it's an inertial manipulation coming through. Sometimes you get a nice little click, sometimes you don't. After that, we'll remeasure eversion. So now his end feel is not quite as stiff, and he can almost feel that difference. So again, 45 degrees, bringing him out and getting into that eversion. So that's the subtalar manipulation, and we'll reassess weight bearing in a minute. So after you do a subtalar manipulation, I learned this from Jenny McConnell, there's a mobilization that you can do with the patient where they're lying on their stomach, if they're comfortable lying on their stomach. If not, you can do it with the patient. Just do some mobilizations in standing, which we'll show in a bit. To get that subtalar eversion, you can have them laying on their stomach and you can just work eversion this way. I mean, there's not a lot of mobility in this joint. At the same time, you have an anterior cervical ligament and a posterior ligament. One has more proprioceptive, it's activity of the anterior cervical ligament, and it's sensitive in that sinus tarsi. And the other one, as I mentioned before, is for energy storage. If you have a model of the foot and you open up the subtalar joint, you'll be amazed at how big the joint surfaces are. So there's an important aspect of energy storage. And as this joint stiffens up, you're not storing energy for your gait to assist you with push-off. So you can do this 10, 15, 20 times to get a little bit more mobility, and then go ahead and flip back on your back and come back here 45 degrees under the sustaneculum tali, and we can look to feel that we're getting that. And it's interesting because it's not like you're going to see a ton of motion, but it used to be like he was blocked right there. Now when we get it, he has this softer end feel. And remember, this joint is designed to work with the body weight going through it. So this is non-weight bearing, so you can't simulate his whole body weight going up through the joint while you do the eversion, and you don't have to. So that's an alternative mobilization, but you test and retest before and after. Okay, so now we'll get you in standing. And facing this way. So after we've done the manipulation, you can look at baseline position and see that he has a little bit more of an angle. And go ahead and twist towards me. Good. And then twist away from me. And if you well, there you go. And twist towards me. And twist away from me. So now he actually moves a little bit better through that joint, and that will help him in the long run as he is working through his gait, energy storage efficiency, etc.